Hi, I'm Jim Cerhan. I'm from the Mayo Clinic and I'm part of the Interlymph Genetics Working Group.
I'm Chris Flowers. I'm from the Pathology and Survival Working Group, and I'm from Emory University.
So we're here to talk a little bit about what's called breast implant associated anaplastic large cell lymphoma. That's a lot of words. And where this came from is about 1997, there were starting to be case reports of anaplastic large cell lymphoma associated with women who had breast implants. This is a very rare T-cell lymphoma, and what got people's attention is because it's so rare, breast implants aren't that uncommon, that there might be something going on. However, you can't really make any conclusions from that type of data. The first epidemiologic study to really look at this closely was done in the Netherlands, and there they found, this was Daphne de Jong's group, that the risk of anaplastic large cell lymphoma was about 20-fold for women who had breast implants compared to those who didn't. There was a continuation of more case reports, and then just most recently in 2018, that same group from the Netherlands updated their data. And what they found is that women with implants had about a 300 to 400-fold increased risk of ALCL compared to women who had other types of breast lymphomas. Again, both pointing to that it looks to be a pretty strong association between having a breast implant and having ALCL. Now that's what we call a relative risk. That tells us that there's a strong association, but for patients and public health authorities, we're more interested in what's called absolute risk. And this was the first study that could really estimate this nicely, and they estimated that by age 50, 30 cases of ALCL would occur per 1 million women, and maybe 80 cases approximately per million people by age 70. Or another way to look at this, for about every 7,000 women who had a breast implant, there might be one additional case of ALCL. So this is very rare, and it's and so that needs to be considered. Just a couple other points. The ALCL can occur anytime after the implant. Most commonly, though, it's 10 to 20 years after, so being aware of symptoms is important. It has never been shown to occur in smooth implants, only in textured, and then there are micro-textured and macro-textured, and it seems to be stronger in the macro-textured. The last point is that they tend to be very indolent, and Chris will talk a little bit about the clinical characteristics of them.
Now, this is a disease that tends to be a little bit confusing from a biological standpoint. The anaplastic large cell lymphoma associated with breast implants looks like anaplastic large cell lymphoma, the typical T-cell variety lymphoma under the microscope, which tends to be a very aggressive behaving lymphoma. Although breast implant associated anaplastic large cell lymphoma is not. It's a more indolent behaving lymphoma. Under the microscope, it tends to be positive for CD30, the marker on the cell surfaces, and it tends to be negative for the marker ALK, or the anaplastic lymphoma kinase, which is also associated with more aggressive behaving lymphomas in the other settings. But unlike those lymphoma subtypes, it is less aggressive when it's associated with the breast implants. This is an entity now, because of the way that it behaves, it's been created as a new entity in the World Health Organization classification of lymphomas, and so is newly described for that particular purpose. And overall, this is something that, as Jim mentioned, is very rare. There have only been about 600 cases described worldwide so far. When we think about how to manage this disease clinically, in years gone by, people tended to get chemotherapy as the treatment for this because of the way that it looks under the microscope, like other anaplastic large cell lymphomas. Now we know that with breast implant associated lymphomas, which tend to be more common with the textured implants, as Jim mentioned, that this is a kind of lymphoma that typically can be treated just by removing the implant, and the disease will typically go away. One of the things that it's important to make sure of first is to make sure that the disease has not spread outside of the tissue area around the breast. or where the implant is. In the vast majority of patients, it is only localized to that area outside of the implant. And simply removing the implant will get rid of the disease, and careful monitoring to make sure that it hasn't recurred. In the very rare instances when it's spread beyond that area, then more systemic therapies like chemotherapy are often necessary. The Society of Plastic Surgeons have started to evaluate this as a risk associated with implant insertion. And so there's been some debate about the types of implants that this is associated with and the absolute risk. Overall, we don't know still the direct cause of this, but as we've mentioned, that it's more commonly associated with textured implants. And so that's a topic to discuss with a surgeon anytime an implant is being considered. The absolute risk is still quite low, and so many women, after hearing this potential risk, still choose to have an implant placed. And for various either cosmetic reasons or for reasons that occur after breast cancer or breast cancer surgery, that's something that is still sometimes appropriate for women to make as a decision, even given this risk, particularly given that the risk is very low.